Hello and welcome to the training of facilitators for the new Lesotho National Village Health Worker Training Curriculum. My name is Dr. Polly Walker. I am a technical advisor for World Vision International, and I'm the consultant who has been working closely with World Vision and other partners and the Ministry of Health of Lesotho to adapt this content and training material for use in the Lesotho context. I'll be supporting the training remotely from London, and that will mean you'll hear my voice quite a lot throughout this week. We will also have some live question and answer sessions so that I can support you directly. The design of this Village Health Worker programme is intended to transform the way that we do community health work in Lesotho. It addresses the Thrive agenda of the Sustainable Development Goals, and by that I mean that we're moving away from the Millennium Development Goal era of just interventions that look at survival of children to the age of 5, but taking that further to looking at interventions that enable a child to realise their full potential. This meets the changing health needs of the demographic of Lesotho, in particular rural populations where the demography is changing rapidly. We're seeing greater numbers of elderly people with poor access to healthcare. We're seeing skipped generation families, and we're also seeing teenage and child-headed households. We wanted the programme to encompass the core health needs, not just for the mother and newborn, but for the whole family, and that includes adolescents, adults and the elderly. However, in order to expand the programme, we need to be more strategic, so that means targeting the most vulnerable and marginalised families that are experiencing the greatest health equity. Beyond just looking at an intervention-based approach, we'll be training village health workers to look for social determinants of health and to tailor their approach to each family in order to address those, in order to basically break the generational cycle of poverty and poor health. And also, we wanted to harmonise the way that village health workers do behaviour change communication across all the key innovations in the Village Health Worker programme that you will identify. First and foremost, it is an integrated service delivery mechanism. So rather than doing topic-wise visits, like a topic visit on nutrition or newborn care, for example, we will see that each visit is tailored for specific needs, and so groups of messages are applied together. We have included whole family health, so taking the life course model beyond the 1,000 days framework to the whole of life community healthcare, which appears to be the great need in rural communities in Lesotho. We've included a mental health approach, so as a cross-cutting theme across the content, you will see reference to maternal mental health and psychosocial support needs, and the underlying causes of poor mental health, such as intimate partner violence, sexual violence and acute mental health. So we've applied a psychological first aid approach. Early child development is embraced throughout the curriculum in both timed and targeted counselling and healthy families, and that includes looking at play opportunities but also child safety and child protection. Timed and targeted counselling is the larger curriculum of the two, which looks at maternal and child health through the 1,000 days framework. However, you will also see in healthy families that we take a timed and targeted approach using storybooks that encompass the different age categories up to 19 years of age. Throughout the curriculum, there is the promotion of positive engagement of fathers. So that's not a compliance-based approach, but in actual fact, it's just about getting fathers to participate and feeling and understanding what their positive roles could be in supporting family health. These are the two packages that you'll be learning this week. First one is Healthy Families. So Healthy Families encompasses all the basics, and we recommend that this is trained first for the village health workers. The reason being, it starts out with community mapping, basic disease and birth and death surveillance, notifiable disease response, and a systematic assessment of households, including the registration. So that's really an entry point for the village health worker programme. Also within Healthy Families, you have management of basic complications, so the common injuries and accidents and first aid response, but also the need for care of sexual violence and rape cases. The bulk of the service package within Healthy Families is called the routine or integrated household visit, and that has two components. So there is the household assessment first, or healthy home, and that is going to look at 4 dimensions, so water, sanitation, and also food security and nutrition, and then the child safe home. From there, you also look at the routine care of the child, so that's children aged 2 to 5 that will be seen on a routine basis to look at vaccines, vitamin A and deworming, and good nutrition. Then we'll move on to the adolescents and elderly care, including sexual health and family planning. And we include disabilities and chronic diseases, non-communicable diseases in particular, that are on the rise in Lesotho, and care for the elderly right up until death. So palliative care is included in Healthy Families. In the other module, time to targeted counselling, you see it is structured slightly differently. There is the first unit, which is around the basic skills and competencies, and then you have a structure which follows the visiting schedule from pregnancy right through to 2 years of life. There are additional modules which provide for the supportive care of the most vulnerable for each group of people. So vulnerable pregnancies may include adolescents and HIV positive pregnancies, and small babies. The newborns that need extra care are small babies, HIV exposed infants, orphans, and anyone with a disability or congenital malformation. But we also provide support for the most vulnerable mothers and children. Unlike other adaptations of TTC, we've actually included integrated community case management for diarrhoea, pneumonia and malnutrition, as requested by the Ministry of Health. So that includes care for sick children aged 2 to 59 months. In that, most of the content you will have seen before, but there is some new additional content around home-based support during CMAM treatment, and that includes something called a root cause assessment. So here you see the integrated service package, so 6 different activities that village health workers will be doing under this programme. So the first activity is community mapping. This is really a one-off event that should be done with the support of the health assistants and district health authorities. However, it should be updated annually. This is where we make sure that the village health worker catchment areas are mapped and that all of the key infrastructure and community resources are in place. Second activity is community disease surveillance, and this is done on an ad hoc basis or during integrated household visits. Any notifiable disease needs to be reported to the district health authority. Third activity is household registration. This should be done as a full registration on the point of community entry, so when you're starting up the programme. And that will take quite a long time because all of the household members must be registered, and there's an identification of different gaps and problems and resources in the home during that process. That can then be updated during every integrated household visit. The integrated household visit is the largest activity of the Healthy Families module. There are 2 components to it. The first is the household assessment, looking at household infrastructure and resources, and secondly is the family health check, so looking at the behaviours, access to services and health needs of each individual cohort in the family, from children to teenagers to adults and the elderly. Activity 5 is the community-based care. So obviously HIV and TB are the big component of community-based care. However, within Healthy Families, we've focused on issues such as malnutrition, chronic non-communicable disease care, and also palliative care. And CMAM support, so any child who is severely malnourished and transitioning away from RUTF to normal family foods, that's encompassed here. And then the last one is time to targeted counselling, which is conducted differently for each family according to gestational age and infant age. So let's talk about Healthy Families to start. So we said we were taking a whole of life approach, so health through the life course. And the rationale behind this is that there is a generational cycle of poverty which can be considered a vicious circle. But equally, if there is interventions across the life course, we can set up a generational cycle of health and well-being, so a virtuous circle. So let's think about how that might work in the perpetuation of poor health. So if you have parents who are not educated or have low access to health services and large families are living in poverty, then they go on to have children with poorer access to health, so less healthy babies, less well nourished, and few early child development opportunities. Those babies, as they grow up, also continue to experience poorer nutrition and hygiene levels and fail to realise their full potential in terms of child development through education and play. Those children grow up to become young people and young adults who don't complete their education, who may experience psychosocial problems, poor mental health, unhealthy lifestyles, and of course have less protection from chronic diseases like HIV and tuberculosis and other sexually transmitted diseases as well. So those young people go on to become adults that have poorer economic empowerment status. They have lower access to jobs, they have poorer healthy lifestyles, and they don't access community support in the same way. So we see the generational cycle being perpetuated. So we need to break that chain. And we will look at the ways that through early childhood we've already started investing through vaccination, through good nutrition and breastfeeding. However, we need to include that early child development so that children's brains are also stimulated, so that they can go on to become children and young people that have realised their full potential. And secondly, the greatest losses in health that are achieved in early life get lost in adolescence. Adolescents are a particularly vulnerable group in Lesotho. HIV levels are very high and disproportionately affect that generation. So we need to look at ways to protect them, to promote healthy lifestyles and support adolescents to make responsible, healthy choices that will prevent disease, poor mental health and HIV. This is the family health card, which is the backbone of the Healthy Families approach. On the first page you see the systematic household assessment, which is the first activity a village health worker will do with the family. You can see that there are 4 quadrants. These are the key factors that influence let's say, the infrastructure of the home and resources that the family have that protect their family and ensure healthy lifestyles. So firstly we have safe water. Secondly, we have sanitation. Thirdly, we have family nutrition. And the fourth sector is safety and nurture. So particularly in terms of family nutrition, we're not just looking at the basic components of a healthy lifestyle, of a healthy nutrition, but we're also looking at the status of the family in terms of food security and access to healthy foods. How dependent are they on financial purchasing of foods, on how much food they actually make themselves? We find that people with access to home kitchen gardens that are able to grow nutritious foods tend to have better status of food security, so we will be promoting that as well. In terms of safety and nurture, there's a complex definition of the child-safe and child-friendly home. That includes having a clean and safe play space where injuries are prevented. It also includes having an emergency plan, so money and plans in place in case of an injury or a danger sign in a child. However, we will also talk about the importance of protecting children from abuse, from parental disputes, and ensuring that positive discipline so children can grow up in a safe and nurturing environment. The village health worker will conduct this assessment and identify any gaps and needs. The second part of the family health card has a family health check, where we've got all the key critical interventions of our health, or the key health promotive actions for each cohort. So this will be conducted alongside the routine household assessment or integrated household visit, and we will look at children aged 2 to 5, covering a range of interventions for survival but also early child development and play. And then for children and young people, we've broken it up into 3 different age categories, and the earlier messages being important for all ages from 6 to 19, and the later ones just exclusively for the older age groups. The adults and the elderly are also addressed, and particularly in terms of the elderly, we're looking at their access to health services, adequate living conditions, and a healthy lifestyle and diet. We often find in many countries where urbanisation is happening, elderly people are left behind in rural communities and have inadequate living conditions which promote poor health and often are malnourished. So for the children, storybooks are also provided which cover all of these messages, and they can be used to counsel the caregivers of children and young people in the household. Once this is completed, the family will be supported to develop a family health development plan. So this is self-determined. Regardless of the number of gaps they have, they're given the opportunity to identify their own priorities and to self-determine. The village health worker will conduct follow-up on a 3 to 6 month basis determined by the level of need. So obviously if there are many gaps on the household handbook, they have to spend more time with that family. If there are no gaps, then the family is doing quite well, and perhaps 6 monthly is all that's required. All the actions are negotiated using a dialogue approach, and particularly we want to involve elder and male household heads where possible. In fact, we implicate them in the assessment approach and in the identification of actions. The reason for that is because of financial accountability particularly, but people who develop their own action plans independently are more likely to be accountable to those actions. This card can then be validated by the supervisor who's conducting household visits to verify that the village health worker is in fact doing the work. So let's look at timed and targeted counselling. We're going to have a much longer session on this, but I just want to do a whistle-stop tour through the key ideas in timed and targeted counselling. If you want to stop and discuss here, you can pause the recording. So TTC is a behaviour change communication approach that happens at the household level. We try to always involve the key influencers and decision makers in the home. That includes, for example, in this picture, the husband and also the husband's mother or mother-in-law. TTC is done using a storytelling approach combined with negotiation and dialogue counselling. It is timed in the sense that messages are grouped into sets and delivered at different times, organised into separate visits. The key messages need to be delivered not too early that they should be forgotten or too late that they are unable to act. The storytelling approach of TTC is very interesting, and I believe personally that this is what underpins the great male involvement that we see with time and targeted counselling, and also the impact. So we always tell a negative story to start with, where we look at the causes and consequences and influence of family members, and the outcome is negative. There are often quite detrimental stories which show what the outcome is, and that puts the family into a little bit of a state of shock, but it does elicit the dialogue, which is really important part. So we see fathers really engaging with the stories and talking about what role the husband had in that. Then we counterbalance that with a positive story. We're not trying to terrify people, we're trying to demonstrate that through simple, achievable steps and through good family and couple collaboration, we can achieve healthy outcomes for mother and child. We've included this element within time and targeted counselling of strengthening CMAM. Okay, so when a child is discharged from community-based treatment and is transitioning away from RUTF, ready-to-use food supplements, back onto the family diet, the village health worker has a very important role in supporting that family to overcome the initial issues or root causes of why the child became so malnourished in the first place. So the first step is to conduct a root cause assessment. So that means not just looking at diet, but also water, sanitation, environmental health, opportunities for play, neglect potentially, and to see what are the root causes that are identified in this family. Is the family food insecure? Is there severe poverty, etc.? So then we support the family to identify a diverse diet using what they have access to, and they ensure the severely acute malnourished child begins to return to an improved feeding routine after recovery. So this was designed because often in CMAM programs we see a small percentage of children experiencing severe acute malnutrition, but often we see the same kids coming back again and again and again because we have not addressed the root cause. The mental health approach that we apply is called psychological first aid. It's not a mental health intervention. It basically works on the do no harm principle. Psychological first aid is how to do the first response and identify those women with more serious mental health and psychosocial problems that need extra support. We'll also teach village health workers about the causes and risk factors for mental health and psychosocial problems. Then they will conduct sort of interview to look at the positive or negative coping strategies that a woman currently does and help them to identify the most positive, and there's particular emphasis on the most vulnerable. This slide is very busy, but there's so much to say about men, I wouldn't know where to begin. But men are the neglected parent, and throughout the Millennium Development Goal era, men were really just involved in terms of being a barrier to health. So we saw male involvement coming out in terms of compliance to family planning and HIV programs, but we didn't see embracing of the positive contributions that men can make to the health and well-being of their children. So we neglect men at our peril. Men are the financial decision makers. They influence the psychological well-being of mother and baby, but they also experience their own challenges, their own health problems, their own mental health issues, especially when their partner gives birth. They have a huge impact on early child development, cognitive and motor skills. As the partner to the mother, they can relieve that burden of nurture that the mother has and play with the children, and that rough and tumble type of play that we often see with fathers is really, really positive for the development of cognitive and motor skills in the infant. Also, men are often the perpetrators of violence in the home, which can be damaging to maternal and child health. But we've also found in studies that men who play with their children on a regular basis experience better mental health themselves and have lower rates of domestic violence and conflict in the family. So the village health worker is going to be promoting male involvement, helping them to access family planning, HIV and birth support for their partners, and also for their own health needs. They need to encourage fathers to participate in home visits, especially those related to TTC, and encourage fathers to play with their kids from birth. They should be participating in healthy families as well and in action planning around improvements. Village health workers can also support if there is a divorce or separation, so brokering the engagement of a father who is not living in the same home as that infant. Furthermore, they could actually conduct fathers and men's groups. And they have lots of storybooks and counselling cards that can be used to address these social norms. So early child development in TTC, we're going to be introducing basic child development messages, engaging the dad, and also the village health workers will be looking for barriers to child development and counselling the parents to overcome those barriers. They will also be taught about the effects of neglect, abuse and violence in the home might have on the child, and identify and counsel the family with these problems. In particular, we'll be addressing family violence and abuse, maternal mental health such as depression, the effects of neglect and poor nutrition, poor health and hygiene in the home. So in particular, village health workers will be trained to identify potential abuse and neglect and to make appropriate referrals. Here's some of the evidence behind TTC. I like this picture because it shows a causal relationship between the number of visits done and the improvement of a particular practice such as breastfeeding. So this is determining a causal relationship. Although we've actually done evaluations in 12 countries now, we're very confident that TTC has a great impact, especially when done alongside community system strengthening approaches. But here's an example from Ethiopia where you can clearly see that increasing the number of visits will increase the impact of TTC. Here's a study from India. Again, really dramatic results, and these were 2 years apart. From baseline to endline, and we saw dramatic improvements in some really difficult behaviours to change, including contraception, access to family planning, and we think this is down to the family-based approach and inclusion of partners. So lastly, I want to talk about the structure and objectives of the So in terms of the village health worker trainings that you're going to conduct, this is how we recommend that you do it. So you would have a 6 to 8 week preparatory phase where you're going to select the village health workers and the supervisors and prepare all the materials. Lots of printing is involved. Also, you have to purchase some basic simple toys or make some examples of toys that parents can build with their children. So you need a good lag time. Healthy families should take around about 2 weeks, which includes some practical components as well. The village health worker supervisors should then be trained immediately after that. They're then sent back out to the field to conduct their basic activities from healthy families, such as household registration and the integrated household visits. The supervisors will then conduct an assessment in the field and validate that the village health workers are active and are implementing healthy families well. If that happens, then they can progress to timed and targeted counselling. So TTC, again, it's around about 2 weeks, and that will be followed by a minimum 6-week period for follow-up and supervision support in the field. TTC, we also recommend, if possible, you would include some days in a clinic, especially around newborn care and breastfeeding support, where seeing it in practice can be really valuable. Now, HIV/TB care is taken on by roughly half of the village health workers in Lesotho. However, this is not included in this training, so we focused on healthy families in TTC just in the behaviour change communication approach. So you would continue to use the Ministry of Health materials provided for the HIV and TB care. And not to forget that there's always need for a follow-on support, and there is a system in the supervision materials for annual performance review. Literate village health workers. There's a cascade of training, so we're recommending for this 10 days, which is 8 days of classroom, but we do recommend that you have at least 2 days of field practicum. So that means getting out to your districts and trying out the household assessment, hopefully with a mentor with you. And for the supervision, there is in the manual a 1-day field practicum designed to try out some of the supervision materials. And we highly recommend that you follow up and implement these activities right away after your training. Then you would go on to train the CHWs of village health workers and their supervisors. So you would like to see a minimum of 1 to 15, but typically you should conduct modular trainings in pair partners or have multiple facilitators. Okay, so that's it. We've looked at everything that's in the programme. So now we're going to go to appreciative inquiry. I'm going to give you 15 minutes to discuss these things and then report out. So from the positive view, what new components do you see adding the greatest value to your district? So thinking through the Healthy Families approach as a whole, how it includes male involvement, time-targeted counselling, CMAM support, etc. Which of these things do you think are really of great value? And then from the sceptical view, which of these components do you think will present the biggest problems in your districts, and how might your district counterbalance some of those really tricky challenges? That's it from me. I'll see you on the next recording. Bye bye.